Hello, my name is Christopher Chapman. I'm currently an assistant professor of medicine at the University of Chicago, Center for Endoscopic Research and Therapeutics. On behalf of my co-authors, I'd like to thank the GIE for this opportunity to discuss our recent publication entitled Risk of Infection Transmission in Curvilinear Array Echoendoscopes, Results of a Prospective Reprocessing and Culture Registry. The impetus for this study was the relative lack of post-high-level disinfection microbial contamination data for elevator-containing echoendoscopes. Due to recent outbreaks of CRE in patients undergoing ERCP, duodenoscopes have come under increased scrutiny as a possible vector for transmission of infection. According to previous research, we now know that duodenoscopes have a disinfection defect rate defined as the number of scopes positive for microbial contamination after reprocessing of up to 2%. Curvilinear array echoendoscopes have a similar elevator mechanism, however, there's a relative lack of data on this subject. Due to patient safety obligations, we felt it necessary to investigate this issue further. Beginning in February 2015 and extending through February 2016, all CLA echoendoscopes at our single tertiary care medical center underwent prospective bacterial surveillance culturing. Due to the relatively low rate of CRE infection, as well as the need to maintain an adequate supply of echoendoscopes for clinical use, echoendoscopes could be used multiple times in a single day and were only quarantined if a preliminary culture returned positive. After each clinical use, all CLA echoendoscopes underwent standard manufacturer-recommended pre-cleaning, followed by manual cleaning by a reprocessing technician. After manual cleaning, the echoendoscopes underwent high-level disinfection using a DSD Edge reprocessor. The echoendoscopes were then air-dried and hung in a storage closet overnight, and cultures were obtained the following morning. CLA echoendoscopes that were air-dried overnight underwent a 3-sample collection process for culture. These 3 samples included a water-based sample from the suction port, a water-based sample from the water dispense system, as well as a brushing sample from the suction and water dispense system. For the purposes of this study, a primary culture was defined as any culture obtained after at least one new patient contact had been made. A culture was considered secondary if no additional or interval patient contacts had been made, and the culture was only obtained due to a positive primary culture that had necessitated quarantine. For the purposes of this study, any gram-negative bacterial growth with no quantitative threshold was considered positive for culture and necessitating quarantine. During the study period, 540 total cultures were obtained, of which 521 or 96.5% were considered primary cultures obtained from 18 total CLA echoendoscopes. In total, there were 22 cases of positive primary cultures with at least 1 gram-negative bacteria, consistent with a daily culture protocol defect rate of 4.2%. There were 11 different gram-negative bacterial isolates obtained, of which the most frequent were Klebsiella pneumoniae, Citrobacter freondii, E. coli, and Pseudomonas aeruginosa. We had antibiotic sensitivity data on nearly 80% of our positive primary cultures. However, with that data, we had no evidence of CRE, cephalosporin-resistant Klebsiella, or multi-drug-resistant Acinetobacter. Although this study was not designed to follow patients prospectively for evidence of infection, in the available records we did have, there were no documented cases of patient-to-patient transmission. However, there was one patient who underwent an EUS-guided FNA with a culture-negative echoendoscope who subsequently developed a fluoroquinolone-resistant E. coli bacteremia, which then matched the post-procedure surveillance culture. One of the major limitations or concerns with implementing a surveillance protocol, whether it be for duodenoscopes or echoendoscopes, is the cost. During this study period, our center spent approximately $66,327 on culture, supplies, and RN time to maintain this surveillance protocol for both CLA echoendoscopes and duodenoscopes. Despite the similarities in design between duodenoscopes and echoendoscopes, until recently there have been no data reported on the defect rate for high-level disinfection reprocessed CLA echoendoscopes. In our single-center prospective bacterial culture registry, we identified a daily culture protocol defect rate of 4.2%. This study demonstrates that even despite following manufacturer-recommended high-level disinfection reprocessing, elevator-containing echoendoscopes can remain positive for gram-negative bacterial organisms. Given these findings and the relative time it takes to implement design changes in endoscope technology, our institution believes there should be a systematic investigation to determine standards for maintenance and service repair schedules, as well as bacterial burden assessment, as currently each institution are pursuing non-standardized protocols for surveillance of their own design. In our study, 4 out of the 18 CLA echoendoscopes had recurrent positive primary cultures, which reflected the case volume, as those scopes with the highest clinical case volume were more likely to have recurrent positive primary cultures. Now, it's interesting that the recurrent positive primary cultures did not necessarily correlate with our maintenance schedules or our maintenance logs. Therefore, it remains difficult to determine if there were actual physical defects or if it was a failure of high-level disinfection that was cause for the recurrent positive primary cultures. In addition, further studies should be performed in a multi-institutional setting, in which case risk stratification can occur based upon patient comorbidities, as well as the indication for EUS procedure. Further, patients should be followed in a longitudinal prospective fashion to assess for iatrogenic infection. We are now completing high-level disinfection reprocessing in duplicate overnight for all of our echoendoscopes, as this has been demonstrated in duodenoscopes to cause a log fold reduction in bacterial contamination.